Here's a statistic that should unsettle anyone who thinks psychiatric tragedies happen without warning. Studies show that nearly half of people who die by suicide saw a primary care provider within the month before their death, and nearly 1 in 5 saw a mental health care provider. So not a stranger to the system of care, someone who was in the room with a clinician days or weeks before. Now that number is important because in 1 week, a trial starts in Massachusetts that puts it under a microscope. On January 24th of 2023, Lindsay Clancy, a labor and delivery nurse from Duxbury, strangled her 3 young children, Cora, Dawson, and Callan, ages 5, 3, and just 7 months. She had been in and out of psychiatric care for months beforehand. She is not accused of hiding her illness. She is accused of a crime that happened while the mental health system was actively and repeatedly involved in her care. I'm Dr. Suzette Glasner, clinical psychologist and addiction scientist. Today, I want to answer the question that's lying underneath this case, which is how does a psychiatric emergency slip past a system that was actively watching for it? And what does that failure point reveal about every family navigating a mental health crisis? Not just this one. So let's first talk about what actually happened in her case. In late September of 2022, as she prepared to return to work at Massachusetts General Hospital after maternity leave, Clancy's anxiety and depression began to worsen. She saw 2 psychiatrists and was initially diagnosed with what we call generalized anxiety disorder. And over the following months, she was prescribed at least 11 different medications while her condition just continued to worsen. She stopped being able to sleep for days at a stretch. Her thoughts sped up in what we often call a hypomanic kind of state, to the point where she couldn't control them. She started feeling detached from her own life, like she wasn't fully present in it. And most seriously, she began hearing voices that were giving her instructions. And clinically, we refer to these as command hallucinations. They're auditory hallucinations, voices that a person hears that aren't really there, and they are giving commands or instructions to a person for things that they should do. In December of 2022, a women's psychiatric clinic evaluated her and told her that she did not have postpartum depression. Shortly after that, she disclosed to her husband that she was having thoughts of harming herself and the children. She was then hospitalized, but discharged days later with no clinical indication that she was considered a danger to herself or others. She self-admitted to McLean Hospital, which is a well-renowned psychiatric facility, on January 1st, and was discharged on the 5th. On January 23rd, just a couple of weeks later, 1 day before the killings, her psychiatrist increased her medication dosage. So I want to talk about a parallel with what we understand about suicide on why someone being in treatment doesn't necessarily mean that they're safe. And by the way, Lindsay Clancy also did attempt suicide, and her attempt left her paralyzed from the waist down, but obviously she survived it, and she is now going to trial. Research on suicide consistently finds that a large proportion of people who die by suicide, roughly a third to nearly a half, had contact with a primary care provider in the month before their death. And as I noted, nearly 1 in 5 had contact with a mental health care provider. So the uncomfortable feeling underneath this is that people didn't avoid help. It's that they were in the mental health care system, and the system's usual tools, the symptom checklists that we often rely upon, adjustments in medication, didn't catch what was actually happening. And that reframes the way that people usually understand and picture psychiatric tragedy, because the public narrative is usually they needed help and they didn't get it. How sad. The clinical reality is often it's closer to they were getting help. The help wasn't really calibrated or suited to the actual level of risk in front of the clinician. And that's sort of a blind spot inside of the system. Now, Clancy's case fits that pattern almost exactly. She wasn't avoiding care. She had 2 psychiatrists. She had a psychiatric clinic evaluation. She was hospitalized psychiatrically. She's self-admitted to one of the most respected hospitals in the country. And an active medication regimen was being adjusted in real time. Multiple professionals, multiple points of contact, right up until the day before. And so the parallel that I want to draw here is that just as the warning signs for suicide can be missed even when someone is actively in care, the warning signs for filicide, or harm to a child, tied to a severe postpartum psychiatric condition can be missed in exactly the same way, inside the exact same kind of system of contact. It's really a similar blind spot pointed at a different, less discussed risk because the base rate of people killing their children is quite low. So it's not something that we're necessarily routinely screening for, but in certain high-risk populations with postpartum psychiatric illness, we really need to rethink that. So here's where I think this case adds something new beside that suicide risk parallel. Clinicians are trained to screen for suicide risk. It's standard in intake and follow-up assessments, and I've done research in this area on how to incorporate it into systems of care like virtual care and even AI-driven care through mental health chatbots to make sure that these types of assessments are routinely administered and we are actively asking the right questions in order to keep people safe. But most clinicians are not routinely trained to ask a parent directly whether they are having intrusive thoughts of harming their child. Researchers who study filicide, or the killing of a child by a parent, describe this as a chronically under-recognized area of clinical education and preparedness of the workforce. It's not that clinicians ignore red flags, it's that identifying this specific risk depends on a clinician proactively asking certain questions that they were really never taught to ask, rather than waiting for a parent to volunteer it. Filicide is also, as I noted, statistically rare. So it's rare enough that many clinicians may go their entire career without encountering it. And so when you have these sort of like rare, high severity events, this is what human kind of pattern recognition is really worst at catching, because there's no accumulated experience to calibrate against. So a psychiatrist who has seen hundreds of anxious, depressed, sleep-deprived new moms has a mental template for sort of what's a postpartum struggle. And rarer would be the template for a postpartum struggle that is severe enough to end in filicide, because they just haven't encountered or seen it that much clinically. So that rarity is dangerous for detection of a risk in somebody like Lindsay Clancy. So researchers who study these cases of filicide tend to classify them by motive. So is it altruistic, where they think that they were doing something to save their child from an ugly world, acutely psychotic or out of touch with reality, an unwanted child, spousal revenge, and a few others. And because the risk profile and the warning signs differ meaningfully by category. In Clancy's case, and the defense's own framing of severe bipolar disorder with psychosis, this really places it squarely in the acutely psychotic category, not revenge or rejection of a child. And that is a distinction that coverage in a true crime context can often blur. And just ask about thoughts of harm isn't that simple of a fix, because intrusive thoughts about harming an infant are actually common in postpartum depression and OCD. So one study found that nearly 60% of women with postpartum depression reported them. But those thoughts are what we call ego dystonic. So ego dystonic means it's really inconsistent with who the mom feels that they are and what their value system looks like. So the mother is, when it's ego dystonic, when it's happening in the context of depression or OCD, the mother is horrified by it. These thoughts, she knows they're wrong. She feels really guilty that those thoughts exist in her mind, but there's no evidence that they actually predict harm. If anything, the mom becomes hypervigilant and protective and worried about harming their child. So that's categorically different from postpartum psychosis, where the thought, the intrusive thought, the command hallucination are actually believable to the mom. And that's where risk can start to climb. So infanticide risk in postpartum psychosis runs roughly 1 to 4% and climbs more than fivefold when psychosis co-occurs at the same time as depression, as it seems to have been in the case of Lindsay Clancy. So the expert recommendation isn't just screen for thoughts of harm, it's screen routinely and non-judgmentally, and then train clinicians to distinguish this thought horrifies me from I believe this thought is true, and bring a partner or a family member into the risk assessment, since a person experiencing psychosis may not have the self kind of insight to accurately report their own symptoms. They may not recognize it as being totally abnormal or really understand how ill they are and the fact that the thoughts are a reflection of that illness. So that matters here specifically because it was Clancy's husband who first flagged her disclosure to providers, not a screening tool that caught those thoughts of harming the children independently. So I want to spend a moment on what you should do if you see something like this in a loved one or are worried about this. Most of us aren't clinicians, but many of us have watched a partner or a sister or a friend after having a baby, and family often spot this before any provider does. The red flags are fairly specific, so little to no sleep for several nights running, extreme agitation or rapid mood swings, disorganized thinking, paranoia, delusions, especially involving the baby, and hallucinations. And the onset can be pretty fast, so it can appear within a few days of delivery, but most cases begin emerging in the first couple of weeks postpartum. One pattern that families consistently misread is that a woman with postpartum psychosis can look acutely unwell at one time of the day and then seem like herself again hours later. The waxing and waning looks seems to imply that the person is getting better, but clinically it could be the opposite, not a sign of recovery, and that's something to look out for. And here's why family vigilance is really important, because someone who's in the middle of a psychotic episode frequently doesn't know that she's unwell. That's that insight piece that I was talking about. So impaired, what we call insight or self-understanding that one is unwell or has concerning symptoms, is part of the illness, which means that the people around her may be the only ones who are positioned to act and to be helpful. So when should someone sound the alarm? Immediately. It doesn't require certainty, just reasonable concern. If she's showing these types of signs, especially confusion, delusions, or any expressed thought of harming herself or her children, she really should not be left alone and not left alone with the children. And this isn't like a wait and see kind of situation. It really calls for same day kind of emergency evaluation, 911, an ER, a crisis line, since postpartum psychosis is a full-on psychiatric emergency, and involuntary hospitalization could be appropriate if a person in this situation can't recognize that she's unwell. Families can also call 988 or reach out to the National Maternal Mental Health Hotline at 1-833-852-6262. Now, one caveat that I should add is that most women with postpartum psychosis with prompt treatment do not harm themselves or anyone else. This isn't a reason to panic at ordinary new parent exhaustion. It's a reason to take the severe signs seriously and act quickly, because by the time she can ask for help herself, she may no longer have that insight to know that she needs it. Now, I just want to spend a moment on the legal picture for her case and sort of where this case stands right now. Clancy's defense has centered on an insanity claim from the start. Massachusetts law allows a defendant to be found not criminally responsible if a mental disease or defect prevented her from understanding or appreciating the wrongfulness of her actions or from conforming her behavior to the law. Her defense plans to argue that she was experiencing bipolar 1 disorder, a severe mood disorder with psychosis and anxious distress, with onset postpartum, a more severe presentation than postpartum depression alone. At this week's pretrial hearing, the judge denied a defense motion that would have let other women testify about their own experiences with postpartum mental illness, ruling the defense hadn't met basic discovery requirements. Now, that's a bit of a setback for a strategy that's built on showing the jury that this isn't a fringe experience. The judge also ruled that he'll seat an unusually large jury, 18 people, including 6 alternates, tied directly to just how emotionally difficult this material will be for jurors to sit through. And there's a live, unresolved fight over jury instructions. The defense wants jurors told up front that the prosecution bears the burden of proving Clancy was not suffering a mental disease or defect. Prosecutors are saying that that's premature before expert testimony, and how and when jurors learn who carries that burden can really shape how they weigh everything that follows. A lot of controversy in this case and the way that it's being handled. The trial begins on July 20th and is expected to run 4 to 6 weeks. I don't really think that this case is well served by the question true crime coverage usually asks, which is, how could a mom do this? The more useful clinical question in my mind is underneath it. How does someone get 11 medications, 2 psychiatrists, a psychiatric hospitalization, a psychiatric clinic evaluation, and a self-admission to a leading psychiatric hospital and still end up at this outcome that this case represents? The suicide contact data, or the relationship between suicide and contact with the mental health and a primary care healthcare system, tells us that being in treatment isn't the same as being safe, because our usual tools weren't really built for these rare, severe cases that are hiding inside a much larger population of people who do get better. The Filicide research tells us that we haven't really built this tool yet. Most clinicians were never trained to ask that specific question that might have surfaced this risk directly, especially those who are not practicing in the field of mental health. And those are the clinicians that these individuals are more frequently seeing shortly before they commit these crimes. So put all of those together, and this stops being a story just about one mom in Duxbury and a horrendous crime and tragedy, and it becomes a story about the limits of how we screen for and respond to catastrophic risk across mental health care generally. I hope that you learned something valuable today, and I look forward to seeing you next time.